We've been talking about dieting and we've been talking about body dissatisfaction. Today, I want to touch on subclinical and clinically diagnosable eating disorders. So, I call this lecture the perfect storm. And it's because one of the most frequently asked questions that I get is, how do you develop an eating disorder? And I think there are a lot of myths and misconceptions about what an eating disorder, quote unquote, looks like, who it affects, who is vulnerable, and what the trajectory of it actually looks like. So there's no profile for eating disorders. It affects all ages, racial categories, ethnic categories, gender identity, socioeconomic status. It's not like we can just look at someone and say, oh, they're going to have an eating disorder, or oh, they have an eating disorder. And similarly, there's no one factor that suddenly flips a switch and makes you have an eating disorder. This is something that develops over time, and it really does evolve from kind of the perfect storm of certain life events pushing someone into using food, exercise, or restriction around food and exercise as a way to cope. And that gradually leads to more and more disordered ways of thinking and behaving in terms of our relationship with food, our relationship with our body, our relationship with exercise, and then could ultimately lead to a clinically diagnosable eating disorder. So what does this look like? So eating disorders, again, don't just develop overnight. Often it takes years for someone to kind of first become vulnerable to actually be able to be clinically diagnosed with an eating disorder. So at the hallmark of most eating disorders, not every eating disorder in the DSM-5, there are a number of different food and eating related disorders in the DSM-5, and not all of them focus on body image, but the ones we're going to talk about and the ones that you probably hear about most commonly do. So the underlying mechanism that we're first looking for is a level of body dissatisfaction that has developed over time, right? So again, going back when we were kids, if left to our own devices, we felt probably pretty good about our bodies, and we ate what we needed and the appropriate calories. We didn't worry about food in and energy expenditure out. It wasn't a thing. So we were flexible with our eating. We ate in a pretty healthy way, got enough calories over the course of a few days for our body's growing needs. We had confidence in ourselves and our body shape and our body size. But as we've talked about throughout the course, as we grow up, we get exposed to not only food ways and food rules, but a lot of media messages or messages from family, friends, other loved ones, school, that tell us that actually we're not okay with what we look like. And so we sometimes will then become preoccupied with food, with dieting, with attempts to change our body size and shape. And we talked about before in this class, recent studies suggest that 80% of 10-year-old girls in the United States have already gone on a weight loss diet. So again, trajectory. So 3 to 5, we know fat is bad and thin is good, at least in the US in our verbiage, in our lexicon. By age 10, about 80% of girls are already playing with food restriction. And as we just continue to grow up, the preoccupation, the dieting can turn into disordered eating and unhealthy dieting, a lot of distress about body size and shape. And this is typically when we would think about someone meeting a subclinical eating disorder. So one of the readings that I have for you in this week's module is a reading about EDNOS or OSFED. So that's kind of a catch-all for a lot of what we call a subclinical eating disorder. So they don't quite meet the criteria for anorexia nervosa or bulimia nervosa or binge eating, but clearly there's enough disordered thought processes, enough disordered eating and exercise habits that it is a problem and probably should be treated. And then we go to kind of the full-on eating disorder and disturbed body images, the diagnoses that we commonly think of: anorexia nervosa, bulimia nervosa, and binge eating disorder. So the body dissatisfaction leads to an attempt to do something about it, usually in an unhealthy way. We then get to disordered eating or the subclinical eating disorders, and then to the clinically diagnosable eating disorders in some individuals. So I'm not going to go over the DSM criteria. If you've had abnormal psych, I'm sure you've covered it in that class. Pretty easy to look up, and I've got some links in your module for you if you're interested in knowing more about the clinically diagnosable criteria for all of the eating disorders. But what I want to do is really address what are we looking for. So if you're worried about a friend or a loved one, and you're afraid that they may be walking down the road toward an eating disorder, I want to cover kind of some of the emotional, behavioral, and physical signs that are fairly common with anorexia nervosa, bulimia nervosa, and then binge eating disorder. So anorexia nervosa is often one of the most recognizable eating disorders only because one of the diagnostic criteria and warning signs is dramatic weight loss. So this is someone who was at a normal weight or even overweight and suddenly is now severely underweight, or they've just lost a lot of weight in a very short period of time. And going along, there's no health reason for it, right? Going along with that, there's a lot of preoccupation with weight, food, dieting. They're afraid. They're afraid of eating. They're afraid of gaining weight. They're afraid of being fat. And so that preoccupation turns into an actual fear. Anxiety is very commonly co-occurring with anorexia nervosa for that reason. They have a lot of very restrictive rules about food. They may eliminate entire food groups or certain foods or categories of food. They have a lot of food rituals around the when, the what, the how, the why they can eat. If they feel hungry, they say they're not. And consistently just start avoiding food, avoiding meal times, avoiding situations that involve food. Physically, a lot of times these individuals are malnourished because they're not eating enough calories to sustain their weight. So along with that, with the malnutrition and the lack of calories, a lot of dizziness, maybe have fainting spells, feel cold all the time, cold hands, feet, have trouble sleeping because they're hungry and they're in denial of the fact that they're hungry. A lot of times skin will start to get really dry. Sometimes hair starts to fall out. If they've lost enough weight and they're female and of an age where they normally would be menstruating, oftentimes that either stops or their periods become very irregular. Impaired immune function, it's really hard for your body to heal when you are constantly calorie restricting. And then gastrointestinal complaints. So the further along you would get with food restriction, our bodies kind of start rebelling when we do eat. And so there's a lot of bloating oftentimes accompanying mealtime or a kind of what looks on the surface to be a food allergy that actually is just the body kind of freaking out because it doesn't know what's happening and why food is being so restricted or only eaten at certain times of day. Stomach is always grumbling because you're always hungry, that kind of thing. So just a very broad overview. Again, not diagnostic criteria, but just if you're looking for warning signs in others or in yourself, these are some things to think about. Not all of these need apply. We're looking for consistencies in a few of these, right, as being warning signs. Bulimia nervosa. So evidence of binge eating is kind of the early warning sign of this. And so if you're a parent or a sibling, if food starts disappearing in large quantities, I had a student in this class once who kept finding her son. Her son was complaining about being cold, and she went to his floor vent and she found a bunch of candy bar wrappers stuffed in the floor vent where he was binge eating and trying to hide it from her. So he stuffed the wrappers in the floor vent, and then of course that cut off the airflow, so he was cold because the heat wasn't able to get through. So finding hidden food wrappers is, if you're a roommate, is often a warning sign. Evidence of purging. So bulimia nervosa, there's the binge, and then there's also the purge. The purge could be through exercise, it could be through vomiting, it could be through laxative use, diuretics, diet pills. There's a fasting, there's a number of different ways that the purging can be accomplished. So evidence of purging behavior, someone's always getting up and going to the bathroom immediately after eating, or you hear them throwing up, right? I mean, that's a good warning sign there. Mood swings, a lot of cognitive changes happening with that binge purge behavior, centering around a lot of shame, oftentimes. Shame, guilt around food, around eating, and then around the purging episode. Physically speaking, again, maybe noticeable fluctuations in weight, maybe not. Those with bulimia nervosa don't always lose weight, so that is not a hallmark like it is for anorexia nervosa. Body weight's typically within the normal range, may even be overweight. One of the first healthcare professionals that often knows someone is binging and purging in particular, is the dentist. So as you vomit, the stomach acid comes back up with fat, with the food contents, and so that can actually start to erode your enamel, causing cavities, causing tooth sensitivity. So sometimes, because you can't tell by looking at someone if they have bulimia nervosa, the dentist is often the first person to figure it out. May also be cuts, calluses across the tops of finger joints if they are using their finger to force themselves to throw up, sticking their finger down their throat. Difficulties concentrating because of the constant obsession with food and how they're then going to, what they're going to eat, how much they're going to eat, and then how they're going to get rid of it. Again, not diagnostic criteria, but just some warning signs to look for if you are concerned about somebody. The last one I want to touch on is binge eating disorder. So some of these are very similar to bulimia nervosa, evidence of binge eating, uncomfortable eating around others. Oftentimes there's a kind of a new practice with food or with fad diets, because again, there's not a purge that's associated with this, right? So it's the binge without the purge, but they're still exhibiting some of those same binging-like behaviors and some of the warning signs you would see for bulimia nervosa, like the hoarding food and hiding food, stealing food. Oftentimes withdrawal. All of the eating disorders share this withdrawal around mealtime or just social withdrawal in general, because there's a lot of guilt and shame around, for some individuals, around having the eating disorder, or they don't want to eat in front of others because they're just not eating, or they don't want you to see them binge eat. There's a lot of things going on that they just don't want you to know about. They may have frequent diets. So again, not purging, but to try to offset some of the binging, they may be a yo-yo dieter. Again, it's based though at that extreme concern for body weight and shape, and there's often the feelings of depression, guilt, disgust, shame around eating, especially around a binge eating event. Again, like with bulimia nervosa, there may be noticeable fluctuations in weight. There may not be. Oftentimes there are stomach cramps and kind of non-specific gastrointestinal complaints that revolve around eating too much food in one setting. May have difficulties concentrating, again, because they're thinking about food. They're thinking about getting that next binge and trying to be good and trying not to binge. This little binge eating cycle chart at the bottom, I really like it because it's simple, but it helps explain kind of what's happening, right? So there's usually an emotional trigger that causes the binge. So again, eating disorders are a coping mechanism. We're going to talk about that more in a minute. And then there's the guilt and the anger and the sadness after the binge of feeling maybe some shame around having binged in the first place. There's that endeavor to be good. Maybe they start a diet, not as a purge, but almost as a punishment for having binged. But there's still those unmet needs. There's still those emotional triggers. And so it's this vicious cycle. So again, these are not the diagnostic criteria. You can look those up in the DSM-5 or consult some of our extra materials in this module. But just some warning signs that you might know and notice in loved ones. So I love this quote because oftentimes there is this misconception that eating disorders are a choice, and it's like a switch you can flip on and flip off, and it's totally up to you, but it's not. It's not a phase. It's not a fleeting affair. It's in a disease that, like an addiction, becomes its own trap. and there's a lot of lying and a lot of impulses, behaviors that they really feels out of control. And so the kind of the guilt and the shame and the hiding that goes around that. So how do we get this? How do we get to this point where we have a clinically diagnosable eating disorder or even a subclinical eating disorder? So as I hinted at the very beginning, it really is the perfect storm. There's no one factor that is going to make someone have an eating disorder. It's a combination of factors. And yes, there are patterns, but just because someone has the pattern doesn't mean they'll develop that particular eating disorder. And just because you don't have the pattern doesn't mean that you will, right? So again, it's the perfect storm. So there is a genetic component for most eating disorders. In particular, anorexia nervosa is about 50 to 60% heritable. And so with someone who's been diagnosed with anorexia nervosa, there's often a family member, either immediate family or larger family unit, that has been diagnosed or shown signs of anorexia nervosa. But again, that's 50-50, right? So it doesn't mean that if you have the gene, you're going to get it, or if you don't have the gene, you're not going to get it. Less is known about bulimia nervosa and binge eating disorder in terms of genetics. The understanding is that there probably is some genetic component to those two, but what that percentage may be is a little harder to pin down than with anorexia nervosa. So the rest of that comes from environmental influences. So a lot of times we see family discord. There may be a lot of fighting. There may be a lot of stress around meal times. There may be a child that's very perfectionistic. There may be impulse control behaviors, depending on the eating disorder in question. Again, there are often patterns of behavior that are common, but it doesn't mean that because someone is a perfectionist, they're going to be develop anorexia nervosa, right? So the perfect storm. It's got to be all the things that happened in the right order at the right time. And we end up with someone who has decided to use food, exercise, or lack thereof as a coping mechanism to control the stress or triggers in their lives. And so over time, the more they do this, the more that becomes an addiction, the more that's enforced as a normal way of doing things, and an eating disorder develops. So as I hinted at earlier, it's not a switch. But gradually over time, it can take years for someone who kind of starts showing a couple of the signs and early warning signs and symptoms to actually get diagnosed with an eating disorder. And one of the reasons is that what we've learned is, in addition to the genetics, your brain is actually changing as you're beginning to engage in some of these behaviors. And so if you're doing a lot of food restriction in particular, we start to see working memory deficits. It's really hard to remember things if you're not appropriately nourished. And that can be true of any of the eating disorders we've just talked about, right? So it's not just lack of calories with anorexia nervosa, because it could be the binge purge or the binge, and then the trying to be good with binge eating disorder. So any time that you're really messing with your diet and what you're eating, potentially you could have some deficits, and that actually begins to affect your brain. And the more you do it, the stronger those effects become. So we see poor planning, poor decision making. It could be impulse control. It could be malnutrition. Again, working memory deficits, even deficiencies in visual processing. So body dysmorphic disorder, which is often a component of some of these eating disorders. They don't actually see themselves as physically accurate. And so if you ask someone who has an eating disorder to draw a picture of themselves, we know that, and we've talked about this before, we kind of in our society have this distortion anyway, where we don't perceive ourselves accurately, but that becomes really pronounced when you have an eating disorder. So for example, someone with anorexia nervosa may see themselves as very fat, even though they are severely underweight. And it's not just that they're making it up. It's that there's something in their visual processing where they don't see themselves, or anyone else for that matter, as accurately in terms of body shape and size. And so over time, again, this develops, and it's like you're laying down this road, you're laying down this track, and the more you lay it down, the more we see these deficiencies. And so when we talk about recovery, it's not just flipping the switch off or flipping it back on. We've got to go back and change the way that your brain is actually altered. So let's talk about recovery for a minute. Eating disorders have the highest mortality rate of any mental illness. And that is for a variety of reasons. So first of all, we guesstimate, again, it's really hard to track this, but when we do surveys and try to see who may be at risk for an eating disorder and ask who's actually sought help, about 1 in 10, about 10% of individuals who meet the cutoffs for a potential eating disorder would actually would seek and receive treatment, right? So 10%. So we have about 90% of people who have a problem that really should be treated and they're not being treated. May not be a fully diagnosed eating disorder, but it's something that's disordered enough in their thinking and the way that they're approaching food and their exercise habits that we really worry about them going down the road of a full-blown eating disorder because they're not getting help and they clearly have a problem. Treatment is most successful when intervention is early because, again, we've got to go back and reprogram the brain. So we have to go through a lot of cognitive behavioral therapy where we're trying to help correct some of the visual deficiencies, and we're trying to beef up the nutrition so they're not malnourished, so they're not having all these memory deficits, and we're potentially dealing with impulse control issues and trying to help with the planning and the frontal lobe issues that are happening over time with an eating disorder. So anecdotally in the world of therapy, we talk about kind of the 60-20-20 rule of thumb. So with treatment, about 60% of those who suffer will make a full recovery. About 20% with treatment will continue to suffer off and on at some level for most of their life. And about 20% will just kind of continue to have the eating disorder. It's like treatment isn't working. They may die, they may not. We hope that they don't. Without treatment, the numbers are a little more severe. So without treatment, it's about 20%, especially anorexia nervosa, but also bulimia nervosa will prematurely die from eating disorder related health complications. It could be suicide, heart problems. A lot of times the purging in bulimia nervosa not only causes heart problems, causes electrolyte imbalances, and that can cause an irregular heart rate and cause someone to die just because they purged too much. For anorexia nervosa, it could be malnutrition. Ultimately, organs just start shutting down, right? So we always want to get treatment if we can. The earlier, the sooner, the better. Here's another problem, though. Another impediment is that inpatient treatment, incredibly expensive, and insurance often doesn't cover it, or if they do cover it, they only cover it until you have weight restored, right? So if we have someone who is not lost any weight, which is very common for bulimia nervosa and binge eating disorder, insurance may not cover it because they're only focused on weight restoration. And if you have someone who has anorexia nervosa, you stick them in treatment, they start gaining weight, and insurance is like, they're cured, they're gaining weight. No, that is a very, very small part of the issue. So $500 to $2,000 per day for inpatient treatment. Again, if insurance is not covering that, you can end up with families' second mortgage on their house, third mortgage on their house, just to try to cover the cost of inpatient or residential treatment. So how do you know? So I want to, again, talk about some early warning signs for yourself, for loved ones, friends, or roommates. I often have individuals who take this class in part because they are sparked by an interest in their own issues with food, or in a roommate, a sibling, a parent, a friend who they suspect may be having some issues. So when we just talk about early warning signs overall of any kind of eating disorder, what are we looking for? This is not a checklist, so it's not like someone has to have all of these things, but if you see a few on this slide and the next one, that might be worth a conversation. And one of the things I have for you in the module is how to talk to someone that you love about seeking help. So be sure to check that out. So dieting, right? Constant adherence to increasingly strict diets, It's more than just yo-yo dieting. It's like the diets just get stricter with each diet that you try. A lot of trips to the bathroom after eating, secretly binging, again, finding hidden wrappers, finding a lot of food wrappers in the trash can, under the bed, hoarding. If they're purging, could be laxative diuretics, diet pills, so you're seeing a lot of that. Compulsive exercise, again, another way to purge. Prescription stimulant medications or illicit stimulant drugs to suppress appetite. Withdrawal from friends, from family, especially around food, especially if you start questioning them. It's the denial, right? It's the denial, it's the shame, it's the guilt. So there's a lot of times withdrawal is an early warning sign. Avoiding meals, situations where food are present, preoccupied with weight, body size, shape, or specific aspects of appearance. It could be anything. It doesn't even have to be weight. Just so focused on appearance. Obsessing over calorie intake and calories burned, even if they're losing weight. So it's constantly looking at those numbers on the scale, the numbers on the output at the cardio machine at the gym, just constantly focusing on what they're putting in and how many calories they're burning. So again, this is not all-consuming. We'd be here all day if I talked about every single warning sign. But if you're concerned and you see a few of these in a loved one or in yourself, it might be time to talk to someone about getting help or to seek resources yourself. There's an entire folder in this week's module of resources for what to do if you suspect you or someone you love has an eating